Hello, I'm Leslie Randall. I am the cervical cancer advisor for the GOG Partners and the GOG Foundation, and have newly moved to the innovaTV Cancer Center to lead the GYN clinical trials there. I am joined by my very good friend, Dr. Brian Slomovitz. Brian, would you like to introduce yourself?
Yeah, sure. Thanks, Leslie. Hi, I'm Brian Slomovitz. I'm a gynecologic oncologist in Miami Beach. I'm the director of gynecologic oncology at Mount Sinai Medical Center. And within the GOG Partners Group, I serve as the uterine cancer clinical trial advisor. Um, but I think, Leslie, we're really excited, right? It's GYN Cancer Awareness Month. So I think one of the big reasons why we're here is to focus on cervix, but just to share some, I know you're always enthusiastic, as am I. We're passionate about this, to share some of the energy we have on the good things that are coming out for our patients.
Yeah, exactly. We wanted to get together and just reach out to everyone that's watching about a lot of changes have been happening in cervical cancer in the last 5 years. And with it being GYN Cancer Awareness Month, um, let's group up and talk about some of the two biggest changes that have happened this year based on GOG partner studies, and that's the KEYNOTE A18 trial, and also the innovaTV 301, the final approval of tisotumab vedotin.
It's so much going on. Why don't we start off? I know you and I are both getting our bags packed. We're going to Barcelona next week for the ESMO meeting, where there's going to
Mhm.
be a lot of great science. But one of the things I was really impressed with, one of the studies actually, that you're came out of your portfolio in cervix, the only GYN trial that's going to be in the presidential session is
Mhm.
the overall survival data of A18. So first of all, congratulations. I know you're very much, it's a labor of love. You're involved with that a lot. And we're really excited. Want to, for a review, want to just go through what that was? I know the data you could share of next week's limited because it's not in the public domain except for a press release, but can you just take us through that a little bit and how finally you help solve the problem in the adjuvant setting or help getting better in the adjuvant setting?
Yes, yes. And I appreciate the credit. We all worked hard on Keynote 18. I think a lot of the, hopefully a lot of the viewers were involved in the trial. We had many investigators in the GOG that participated during COVID. Is, really difficult for this population, and TV 301 was the same. And we'll talk about that. But Keynote A18 was a global phase 3 randomized study that looked at chemoradiotherapy with or without pembrolizumab. And the pembrolizumab was given both during the chemo RT and following that every 6 weeks as a maintenance phase for up to 2 years. And you said it, it's been 25 years since that NCI clinical announcement in 1999, based on those 5 GOG studies that established chemoradiotherapy as the standard. Um, so in this trial, it did show progression-free survival advantage that's been published in the Lancet, as a 0.76 hazard ratio for the intent to treat population. Um, the FDA has already approved pembrolizumab in the United States. It restricted the approval based on stage, and this is FIGO 2014 staging, not 2018 staging. They restricted the approval to those 2014 stage 3 and 4 bulky tumors, and not necessarily to those smaller tumors who had positive lymph nodes.
Let me
Further,
ask you a quick question on that. Let
yeah.
me ask you a question though.
Hmm.
Right now, when you're touching on it,
Hmm.
in your practice, you go see a new patient tomorrow. Are you going to treat them based on the FDA approval, and not give it to some of the ones with maybe a little less bulkier nodes, or are you going to treat it based on the inclusion criteria of the trial?
Yeah, I do treat them based on the label. I do hear the FDA's argument on the the bulk of the benefit being in those bulkier tumors, and the PFS benefit likely being driven by that. I am biased, I will say, because we're running a second trial called Evolve Cervical, and that's a
Mhm.
PD-1 CTLA-4 bispecific. And my rationale is that Pembro helped that entire population of Keynote A18, but maybe it didn't help quite as much in that lower risk group. And so my bias is to enroll those patients to the Evolve study to see if there's
Mhm.
a larger magnitude of benefit for those
Yep. Yep.
patients. But again, I'm biased. I could see really the study was designed to look at the intent to treat population, and it would have been very fair to approve it for the intent to treat. I think a lot of folks
Gotcha.
are treating based on the 2018 staging, not understanding that A18 was designed with the 2014 staging criteria.
Yeah. Yeah. No, these are
What are
all
you
good
doing in
points. I
your
mean, for me,
practice?
what's I'm yeah, for me, I'm using as much as I can. So
Yeah.
I think the study is a positive study. I look at the intent to treat
Hmm.
the statistical primary endpoints, and it met its primary endpoints. So we know IO works in cervical cancer. We know that oftentimes giving something sooner the better. So
Hmm.
I like to use it, but I'm also a big proponent. I don't have Evolve open, but I think it's a good trial, a great trial, and
Hmm.
we want to, it's important to ask the right questions that need to be answered, and that's one of them. So
Yeah,
it's
I think
exciting. Good
so.
luck
And,
with that.
I don't disagree with giving it to everyone, I guess part of me assumed I wouldn't be able to get it covered by insurance. So if
Yeah,
that's not been an issue, that's good for the patient.
got it, got it. So yeah, it's exciting. So congratulations again, presidential session at ESMO to look at the overall survival data. That'll be really exciting.
Great. It is going to be, I would be in the front row, and I'm very fortunate to be able to go. So thank you. And then I think wasn't last year and wasn't TV 301 in the presidential session last year?
Yeah, no, it has. So TV 301 for, just to remind everyone, that's the a second and third line trial of tisotumab vedotin, which is
Mhm.
a tissue factor antibody drug conjugate. The study looked at the ADC versus standard of care, investigatory standard of care, and it found an overall survival advantage. So yeah, and ESMO seems to be the meeting where a lot of this great science comes out of. It was presented at ESMO last year by Ignace Bergot, and subsequently we just had the publication came out in New England Journal of Medicine in July, and
Mhm.
it also got its full FDA approval. Originally, it was accelerated approval, but um, now it has a full approval with a 30% decreased risk of death in those patients treated with TV, which is really cool. Um, and one of the things, and a lot of us know the data, and we're excited to highlight and to talk about the data, and it is part of standard of care. One of the things that I think is really impactful, and part of this is again in your study group in cervix. Not only did it get approval for this overall survival advantage, but you have an ongoing trial now, right? That's in the public domain, the ADC trial. I'm comparing a Trop-2 ADC versus standard of care, and TV is already in the benchmark of what needs to be beat. So it's been so well accepted by the community that it's already a standard of care gold standard. So, um,
Yeah, and the second
it's being used. I
ADC and
use
the Mhm. Go ahead.
no. Go ahead. I'm sorry.
Yeah, that second ADC in the portfolio is sacituzumab govitecan, which is a topoisomerase inhibitor, which how exciting is it to bring a topo containing ADC to cervix, knowing that there is activity of topotecan in cervical cancer, but that implementation has been so limited by the toxicity. I mean, I don't want to give my patients topotecan. They just feel
Right.
terrible on it. So yeah, that'll be really interesting to see, both of those options potentially being available. I think what really impressed me about the TV301 study is, the OS advantage is clear. There was a PFS advantage also, but the response rate was also an analytic endpoint because OS was positive, PFS was positive, and it was hierarchical. Then the
Mhm.
ORR difference was actually powered in
Yeah.
that
Yeah.
study, which I don't know if people actually realize. Um, and it's not necessarily the ORR of TV that impressed me, though it did 17%. It was the response rate to chemo of 5% that you just, we saw it in Empower,
Hmm.
and
Hmm.
we complained about we did these trials in the second and third line because the response rate to chemo was like 15% or less. And when we
Hmm.
looked at
Hmm.
it prospectively, globally, it was 5%. to, non novel therapy. And I thought, I think all of us were just, and now to see that again consistently shown, these
Yep.
patients don't do well on the other available therapies. So new treatments are so important. And, this is a soapbox comment, but, these patients deserve to have access to some treatment. There's
Yep.
this
Yep.
like bias that, oh, they're too sick or they're dying, or, I put patients on second and third line treatment that feel great and want to take care of their kids and want to see them meet hit their milestones. And it may not be necessarily curing patients, but I think it's definitely giving them meaningful, life with good quality
Yeah.
of
Yeah. And these are baby steps. We're not going to, with cervical cancer, we know we're not going to get the one study that changes the world for everyone. But if
Mhm.
you put together A18, and then if you put together the A26s,
Mhm.
and I know we have a slide that we use, when you have chemo, and then we added
Yeah.
Bev, right? 240 Tuari added Bev to the chemo, and then we added the A26 regimen, and then in that continuum, TV, yeah, it's 2-3 months, but it's a 30% statistically significant reduction with a
Mhm.
33% reduction in PFS, with a improved benefit in the response rate. It's these baby steps that are going to make a difference. And not only that, again, TV was a third line trial. Now, if you use the A18, and hopefully you don't have a failure, but if a patient fails, arguably you could use TV as early as the second line.
Mhm.
Maybe even figuring out a way to push it in earlier. And we need to do those studies. And I know GOG, the TV 204 studies, they're doing some things like that, but it's super exciting. And the more we learn about the science, the more opportunities there are to study.
Yeah, no question. And I think that um the only real, the only downside of potentially using TV would be, toxicity. So this is a new class, although ADCs are not going to be, I mean, now we have MERV online and we've got so many coming down the pipeline that, I'm going to feel silly next year saying that ADCs are like new. But, tell me, oh, we also have trastuzumab deruxtecan. So tell me about, the ocular toxicity, neuropathy, and bleeding. I mean, those are the three adverse events
Yeah.
of special interest for TV. In terms of, how many patients discontinued treatment for these, and if they had them, did they get better? What did
Yeah.
that look like?
Yeah. So in general, what we know that the more we use it, the more we are successful at the mitigation strategies.
Mhm.
So what do I mean by that? We have to employ the mitigation strategies. If you wear contact lenses, don't wear contact lenses. We found in the earlier lines of studies, we had a toxicity because people didn't know not to do that. We know to be very liberal with the eye drops, with saline drops to keep the eyes moist. We know to do the appropriate steroid pre-meds during and post, and the ice packs. So once we do that, we found that the ocular side effects, while they did occur, they were much more manageable, and
Mhm.
something that really, not only in the trial, but in practice. And I know you and I are both giving it a fair amount. I don't
Mhm.
see the ocular toxicity to be nearly as worrisome as is portrayed in like the black box warning and the FDA approvals. We need to do more work. We need to really confirm that. But in the study, it's with appropriate mitigation strategies, it was manageable, and very few of the patients actually came off just to the side effects. But we need to translate that practice, the mitigation practice, into in the trenches in the practice, and you know we
Mhm.
need to get to your point, we have limited drugs. We need to do the best we can to get the drugs that work or may work into our patients. And
Yeah,
I'm
no
sorry,
question.
you mentioned neuropathy. It's a different neuropathy than taxane. Really,
Mhm.
when you talk to your patients who are on TV about neuropathy, you have to help them to see what the symptoms are like, and
Yeah.
a lot of times it's manageable and it's limited. But
Yeah,
yes.
so these comments are all resonating with me so much. I found that, my experience was really consistent with what they saw in the phase 3 study in terms of toxicity. The eye toxicity is common, but it's not severe, it's low grade. And when you, if you hold or dose reduce, I mean, these go away. These are not
Yeah.
persistent. The neuropathy for me has been a bigger challenge. You know, I've had a couple of patients have lasting neuropathy, and like you said, it has it can have a motor component to it. So, you know, the first time it happened to my patient, she said, "Well, I fell going to the bathroom." Well, you know, patients can be weak. She was anemic, you know, typical recurrent cervical cancer patient. So it didn't dawn on me until it just kept progressively getting worse after correcting for all the fixable things that it was, you know, hey, this is what that motor neuropathy means that was described. So I think just expecting that, knowing that can happen and being suspicious about it earlier and being able to intervene earlier in terms of dose holds and modifications is good.
Yeah.
Yeah.
All good points. And, these are also important as we move forward. I know you're doing some work looking at combination strategies with TV. It's important to
Yeah.
look at the mitigation strategies, not as a single agent, but in combination. But
Yeah, you
yeah,
know,
this is,
we've combo data with Carbo, with Bev, and with Pembro. Probably the best efficacy data that's out there is with TV Pembro. And you know, all these were happening before these things were moving up to the front line. So now you're like, okay, what do I do with that Pembro treated patient? As most patients who come to second and third line will have seen Pembro. Um, Eventually, I mean, there's like an implementation phase that we're in now right now, but you know, a lot of them will, and can you retreat them? You know, I don't know the answer to that question.
right,
Um,
right.
but for a doubling of the response rate, like I'm willing to try if the patient's interested in that. And we have
Yeah,
the
of course.
toxicity data, and that's very well tolerated. You know, there's no overlapping toxicity when you combine those.
Yeah. Yeah. No, it's exciting. There's um, a lot more coming out. So we're looking forward to next year having another conversation talking about the
Mhm.
discoveries that we had over the next 12 months.
Yeah,
So it's really cool. Well, I'm proud of you, Leslie. I know you're doing a lot of work in the cervix group and
yeah.
your portfolio. It's it's a lot going on there. So I'm excited to see you in the meeting, and we're looking forward to a great Q1 Cancer Awareness Month.
Same, me too, me too. And you're doing great with uterine. And you know, I'm just excited for our patients, right?
Yep.
Um, you know, I'm just really excited for our patients and for them to have these options that are, you know, more durable responses than what we've ever seen with chemotherapy before. And like you said, you move the needle incrementally, but you add up those gains. And right now, if you add up the overall survival, median overall survival gain between Beat CC826 to second line, it's 3 years. So, you
Wow.
know, a patient walks in with metastatic cervical cancer and liver metastases, it's completely not unreasonable to expect that if given proper therapy and supportive care, that she could live at least 3 years. And I know that's generalized, but
Yeah.
you know, it's not someone, you know, these people get told in the emergency room that they need to go to hospice, and that's not true.
Yeah. No, definitely not. There's a lot of good options for these
Yeah,
patients. So
yeah.
yeah,
All
it's
right,
exciting.
great.
Thanks for inviting me to have this conversation with you. It's really, and I look forward to seeing you in Barcelona, um and a lot of good science is going to come out this fall.
Great. All right. Well, stay tuned for other productions from GOG Foundation and try to keep everyone updated on all the great changes that are happening. Thank you.
Great.
Thanks for joining me.
Thanks,
Bye.
everyone.